All right, let's do this. We're about to sit in on a high-stakes oral exam, a consultant-level general surgery viva. And the topic? A true classic, acute pancreatitis. We're going to break down the entire exchange play by play to see how a top-tier answer gets built from the ground up. Ready? Let's go.
And there it is, the first pitch. The examiner lays out the scene, the clock starts ticking, and right away you've got to show them you have a safe, methodical, and really comprehensive approach. No fumbling, just straight to it.
You see, a good candidate already has a mental map. They're not just making it up as they go. They're thinking in sections. Start with the clinical basics. Move logically to diagnosis, then management, and then you've always got to be thinking about the complications. That's the roadmap to success right there.
So, first things first, you have to go back to basics. Before you even think about ordering a scan or a blood test, you need to show that you can get the critical information just by talking to and examining the patient. This is where it all starts.
Boom, that's the perfect opening line. It immediately tells the examiner three things. I'm going to understand the symptom, I'm going to hunt for the why, and I'm going to make sure I'm not missing something else that could kill this patient. It shows you're thinking broadly and safely, not just jumping to conclusions.
And you'd really flesh this out. You'd say, I want to know everything about this pain. Is it relieved by leaning forward? That's classic. I'd ask about gallstones and get a very clear picture of their alcohol intake. And you absolutely have to screen for red flags, like a recent ERCP procedure, which is a known trigger. A detailed medication history is also a must. You're building your case piece by piece.
Okay, the examiner likes that. They see the candidate is on the right track, so they push it forward to the next logical step. They're checking if you can move seamlessly from talking to the hands-on assessment, looking for those specific telltale signs.
This is all about showing you have a system. The candidate would lay it out. I'd start with a general look at the patient and a full set of vitals. Are they in shock? Then it's a systematic abdominal exam. Inspect, palpate, percuss, and listen. It's the classic sequence for a reason. It makes sure you don't miss a thing.
But it's not just about listing findings. You have to know what they mean. Tachycardia and fever? That suggests a big systemic inflammatory response. That epigastric tenderness is your localizing sign. And then you have to mention the rare but critical ones, Cullen's and Gray-Turner signs. Bruising around the belly button or on the flanks, that's a huge red flag for severe necrotizing disease.
So, you've got your story. You've done your exam. Now it's time to use technology to prove your suspicions. The examiner is now looking for a smart, logical use of tests, not just a shotgun approach. I love this answer. It's so clean. You're not just rattling off a list of tests. You're telling the examiner your goals. Confirm the what, find the why, and figure out how bad it is. That's the whole game right there.
And here's how you'd break it down. You'd say, for labs, I'm getting a baseline set including a lipase, which is much more specific than amylase. I'm also getting the markers I'll need for severity scoring later, like LDH and calcium. For imaging, the first test is an abdominal ultrasound. I'm looking for gallstones. A CT scan? That's not for diagnosis, that's for when you're confused or worried about complications.
Okay, this slide is absolutely critical. You have to know this cold. You need 2 out of these 3 things. Now think about our patient. He already has the classic pain. If his lipase comes back at more than 3 times the normal level, guess what? You've made the diagnosis. You do not need a CT scan just to confirm it. Avoiding that unnecessary scan shows you're thinking like a consultant.
Right. The diagnosis is in the bag. Now comes what is arguably the most important decision you're going to make. Just how sick is this person? Because that single assessment is going to dictate everything that happens next.
And there's the question from the examiner. It's direct, it's to the point, and it's a big deal. Because getting the severity wrong, well, that can be a fatal mistake. The candidate has to show they know the objective scoring systems inside and out.
A great answer would be something like, well, I'd use a combination of tools. For the official classification, I'm using the revised Atlanta criteria to sort them into mild, moderate, or severe. But right there at the bedside, for a quick initial assessment, the BISAP score is really useful. And for a more detailed look at prognosis over the next 48 hours, I'd be calculating Ranson's criteria.
Let's look at Ranson's. It seems complicated, but what it's really doing is measuring how much of a beating the entire body is taking. You see a falling hematocrit and a rising BUN. That tells you this patient is third spacing a massive amount of fluid. A score of 3 or more is your signal that this person needs to be in an ICU. It's a powerful tool.
So what do you do first? The answer has to be resuscitate. My immediate priority is aggressive supportive care. That means large bore IV access and hitting them with fluids, hard. We need to get their urine output up. Pain control is vital. We'll keep them nil by mouth initially, but the goal is to get a feeding tube in early, and of course, they need to be on a monitor in the right unit.
Okay, the patient stabilized, the initial fire is out, but the viva isn't over. Now the examiner wants to see if you can think long-term. How are you going to fix the underlying problem and deal with the nasty curveballs pancreatitis can throw at you?
And here it is. This is a classic exam question, and they love to ask it. A sharp candidate gives a very precise answer. Assuming this is gallstone pancreatitis, the timing of surgery depends entirely on the severity. If it's mild disease, you take the gallbladder out during that same hospital stay. But in severe pancreatitis, the patient is too sick and the inflammation is a nightmare. Operating early is dangerous. We wait, at least 6 weeks.
You knew it was coming, didn't you? The examiner throws a wrench in the works. This is the complication we all dread. Infected pancreatic necrosis is a killer, and managing it requires a really sophisticated modern approach.
And the magic words here are the step-up approach. You'd explain, for infected necrosis, the principle is to do the least harm possible. We start with broad-spectrum antibiotics. If they're still sick, we step up to getting a drain placed by our radiology colleagues. If that doesn't work, we can try endoscopic drainage or a minimally invasive surgery. A big, open operation, that is the absolute last resort.
And scene. The candidate has made it through. They've navigated a complex case from the front door of the hospital all the way through a life-threatening complication. So let's pull back and summarize what actually makes for a pass in an exam like this.
So look, the secret to acing a viva isn't just knowing facts. It's about showing you have a safe and logical process. Always have a structure. Always state the severity early because that's what drives your management. Know when to operate, and just as importantly, when not to. Be the person who's always thinking 2 steps ahead, and talk the examiner through it all. Let them see how your brain works.
But wait, just when you think you're safe, the examiner leans in with one last zinger. This one is tough. It's about a late-stage complication and really tests your nuanced, long-term thinking. This is the kind of question that separates the good from the great. So, what would you do next? That's a deep dive for another day.